The content herein is for informational purposes only, not intended as medical advice, diagnosis, or treatment, and is not to be substituted for direct advice from your doctor.
Today's LymphCast program is proudly sponsored by Support MD, the makers of Vein Formula 1000 and Lymphatic Formula 1000. These MPFF-based nutraceuticals are backed by science and recommended by doctors specializing in venous and lymphatic disorders. Visit VitaSupportMD.com to learn more.
Well, greetings and welcome to our LymphCast show, episode 64. Really glad that you are here today. Before we dive into today's episode, though, I want to give a quick shout out to Buy Me a Coffee. That's right, you can buy us coffee. I don't know if anybody on our panel has a mug going, but I certainly do at all times. If you enjoy our conversations and want to support the work that we do at LymphCast Network, head over to buymeacoffee.com/LymphCast Network. Your support helps us to keep bringing you the content that you love, and every coffee really makes a difference. So let's go ahead and get started. Today's show is brought to you by Support MD, founder and owner, Dr. John Chubak. They sell Vein Formula 1000 and Lymphatic Formula 1000. Every one of our shows is on every podcast platform under the sun. We're also on YouTube, and you can find us at lymphcastnetwork.com. If you have a question for anybody on the panel, send us an email at hello@lymphcastnetwork.com. With that, let me turn it over to a physician surgeon from New Jersey. Before I do, though, we have Dr. Emily Eicher here, Dr. Monica Glavitsky. But from New Jersey, we have Dr. John A. Chubak. Dr. Chubak, hello, and now it's your time to roll.
Hi, Paul. Thanks very much. Well, I want to begin by saying I'm sort of envious because you have that beautiful mug and Dr. Chubak still has a paper cup. So I have a long way to go, but I am working hard to improve.
16 ounces, Dr. Chubak. 16.
You remain an inspiration to me, Paul, in many ways.
We're on a budget over here.
Exactly. So anyhow, it is, tonight's a very wonderful experience for me personally because it's my privilege to introduce Dr. Kirsten Kleppe to the program. And if I'm not mistaken, and she can correct me, which most people do, I think that we actually met through LinkedIn, which I think is a wonderful, wonderful resource. And so it's difficult for me to personally introduce her other than to say that I've looked at her CV and her credentials. And not only are they impressive, but extremely fascinating. I really want to learn more about her and have her share her story with us. Tonight's show is really focused on lipedema surgery. That's the essence of what we're really going to get into. But Dr. Kleppe has had such an interesting training journey and personal journey, it seems. I want to learn more about that. She is a plastic surgeon, Norwegian plastic surgeon who is building a great reputation for herself, specifically in the area of lipedema surgery, although her training goes far beyond that. And without going into too much detail and giving away too much, I want to introduce Dr. Kirsten Kleppe to the program. Doctor, welcome.
Hi, thank you so much for having me.
It's a pleasure. Let's begin, if you don't mind, with me asking the first question, which is a little bit repetitive, but I think it's so fascinating. And looking at your CV, I think that you have done more traveling in your life than I'll do in 100 lifetimes. So if you can tell us about your own personal journey, I find it so fascinating.
Yeah, so traveling is definitely something that has been a part of my life. My parents are a little bit international. You can probably hear that I don't have that Norwegian accent. So I'm actually American. My parents are both from the U.S., but my dad grew up in Japan, and they've sort of ended up meeting in Norway, and then the rest is history. We ended up staying in Norway and establishing ourselves here, and traveling has just been a big part of life. So I've been traveling since I was 6 months old. And that's just kept going. So I love the opportunity to be able to travel to visit friends or have opportunities to do like medical outreaches. So
that's wonderful. Well, I know that that's something you're going to find that you have in great common with Dr. Eicher and Dr. Glavitsky, who, unlike me, are great globetrotters and have been all over the world. Tell us a little bit about your the essence of your medical training and your background and how you came to be a plastic surgeon with this interest in lipedema, please.
So I actually knew I was going to be a plastic surgeon by the time I was 16 years old. I'd been on a medical ship that traveled down the coast of Africa that was in our port in town. And I saw the pictures that showed before and after of like cleft lip, cleft palate, noma, big transitions, changing people's lives. And I was like, I want to do that when I grow up. So I went to medical school in Hungary, graduated in Budapest, and then did my residency in Norway. And, the cool thing about medical school in Europe, when you have your last year, it's like a practical year. So you can actually, choose where you want to do your sort of like internships. So I traveled to India and Israel and Nepal and did obstetrics and gynecology, internal medicine. And I worked in the ambulance system in Tel Aviv and did trauma surgery there. So I got to experience a lot of kind of medicine that you otherwise wouldn't back home in Norway, where things are a little bit more, general run of the mill, not that exciting. So that also, helped inspire the way on. But it's been a tough ride. Getting a fellowship or getting a residency in plastic surgery isn't just a walk in the park. So it's been a lot of hard work, but it's been worth it. And I've been in a lot of different subspecialties. So when I was working in the public hospital, plastic surgery also includes hand surgery. So we were doing a lot of hand surgery and general plastic surgery with a lot of breast reconstruction related to breast cancer, and then microvascular surgery. So did I answer your question?
Yes, of course you did. You've said a magic word, and Monica's jumping out of her seat. And this was my surprise for her.
Why I'm jumping? No, I'm so fascinated because I'm very much involved with Semmelweis University. Which has to be your alma mater, as I understand.
That's right.
Yes, and so my first question: why Hungary? Because you had another choice among the European schools, and have you learned Hungarian?
Igen, and beszélsz egy kicsit magyarul?
Yes, you should.
Yes. So,
isn't that a beautiful world?
Absolutely.
The American origin girl finishing the medical school in Hungary and speaking Hungarian. Believe it.
Yes. So the reason why I ended up in Hungary is because the Norwegian government, we get our education subsidized. So we get a grant and a loan for our continuing education. And they've had a push for, at the time that I was studying, it was Hungary. And then afterwards it was Poland. So they've had like agreements with different universities, and there's been a lot of, because there's not enough places.
You're saying all the magic words tonight from Monica. We went from Hungary to Poland. We're in trouble.
Well, okay. So let's finish. Let's go for a coffee, Kirsten.
Okay. Sounds like a plan.
Exactly. So I love all this personal stuff, of course, but we have to serve our listeners and our patients. So let's get to the subject. Monica, Emily, let's get some questions for the good doctor regarding lipedema surgery, please.
If I may ask, why lipedema? You were involved with so many exotic plastic surgeries, and
I still am. I don't do just lipedema. So that's become a big focus now the last year and a half, 2 years. So I think one thing that's been happening is that there's been a lot more media attention around lipedema. I had my first lipedema patient at the public hospital when I was working there about 7 or 8 years ago. And I didn't really know very much about it at the time. I was like, had to study up on it. I was like, what is this? Why do people get this? And, and so I sort of dove into it, and I started treating my first patient, and there was these Facebook groups that the lipedema patients are on, and it went like wildfire. There's a doctor that's operating lipedema in the public hospital. So all the referrals got sent to me, and my boss was like, stop, we're not doing anymore. We don't have the capacity. And so that sort of shut it down. But the patients that I'd gotten in at the time, I was allowed to finish their treatment. So that was my first sort of dabble with lipedema. And then when I started working in private practice 2.5 years ago, there's no actual coverage in the government healthcare system for lipedema here in Norway. There's a study that's going on, a 5-year study, and they've had an intake of a certain number of patients, and with incredibly strict criteria, so that the majority of the people with lipedema don't get into the study at all. And so there's nowhere to go except for private practice. So when I started, I bought 2 machines. I bought Vaser and Renuvion, and I have a power-assisted liposuction machine. And those together were sort of like, well, now I can do any kind of liposuction I want to. And I've treated lipedema before. There's a big hole in the system. How can I help? So and also there's not very many doctors that are comfortable with making the diagnosis of lipedema. So I started, systematizing that and getting that in order. And then, so there's a lot of patients that come to me just to get the diagnosis so that they can go forwards with the compression therapy, physical therapy, all this stuff before they come to me later for surgery.
I see. So congratulations that you are opening doors in Norway, where probably everybody's with the nice warm clothing and coats, so you don't see much lipedema.
Well, you know what? I think that after having treated so many lipedema patients, all I see are legs when I go to the airport and traveling. I'm so I feel like I'm just sort of damaged goods with I want to go tell people, do you know you have lipedema? But I don't.
Passing the cards, yeah.
Yeah. So, it's not as cold here in Norway as one would like to think. It's a lot milder climate, and with the recent changes in weather and stuff, things are getting it's more rainy than it is cold, unfortunately.
Question is also, so what within your traveling and seeing different kind of the medical practice, what is noticeable for you between the Western and Eastern medicine and maybe Asian medicine? I don't know if you could comment about the different approaches maybe to the professional or physician or specifically in your plastic surgery domain.
Sure. So I did have a fellowship in microvascular surgery in Taiwan. I don't know if any Asians actually have lipedema. I have not seen any, large. Correct me if I'm wrong, but I don't think they have lipedema. Have you seen? I think it's when I was in Thailand in October at a conference, and looking around at people's legs, they're pretty much normal. There are some more stocky built people, but not kind of lipedema that you see in Europe.
What do you say about that, Emily? Do you have any? Because you go to these international conferences.
Not only that, years ago, I used to say, well, I have not seen Asian lipedema yet. But the next day, I saw a lady down in our pharmacy. I was looking at her. A few days later, she became my patient, and she was Chinese origin. Mother was Chinese. The father was Chinese. Mother was Eastern European. And guess what? She had lipedema. And right. I saw another one from Philippines, from Manila. And she was so proud of herself that she's not pure Filipino because she has Spanish background from grandparents. And so if you have pure Asian, you don't see the lipedema, or I have not had the opportunity seeing lipedema on pure Asians. But if you have a mixed cultures, and especially with Eastern European, where you see a lot of lipedema, then yes, you get to see lipedema.
Oh, interesting. It's fascinating.
Yeah.
Yeah.
So,
And, and what I noticed, but it's like the digression. Actually, you have within the Taiwan medical school, you have so many people interested in lymphatics. Could you comment about it?
Absolutely. There's a huge lymphedema problem in Asia and in Taiwan. I mean, we did some pretty drastic surgeries. We had one patient that had chronic lymphedema that we basically we took all of his skin off as a partial skin thickness graft, and then we took out all of his fat, just cut it off all the way down to his muscle. Did a lymph node transfer from the gastrojejunal lymph nodes, and then connected those to the popliteal fossa, to the lymph nodes down there, and it was pretty fascinating to see how different his legs looked afterwards. And we also did a lot of lymphovenous anastomosis, which also you could see a difference almost on the table once they were connected, how much softer their legs got.
Yeah.
So
and you know that the Hungarian school now, it's pretty much connected to that Taiwanese world, because the surgeon, the microsurgeon, plastic surgeon, who is working on a lymphatic microsurgery now in Budapest, was trained by Professor Zhu, who is from the Taiwanese school, actually, but working in Vienna. And it's very interesting connection, and I think that fascinating progress that was done in that surgery.
I think Dr. Ming Kang is the father of Taiwanese school, the Taiwanese lymphology surgical intervention. And a lot of our Dr. Patel and few doctors were trained by him. And they are now very successful with lymphatic and lipedema surgeries.
Well, it's very interesting to hear this story of this quite radical operation that you describe, doing basically lipectomy down to the fascia on these patients. Are you familiar with a colleague not too far from you, Dr. Håkan Brorson?
Absolutely, yes.
Yeah. Håkan has been a guest on our show. Thank you to Emily for making that introduction. And we had a fascinating discussion, and he showed some extraordinary before and after pictures, which were mind expanding for me personally, to see what could be done with liposuction in primary and secondary lymphedema. And so that's, I think, work that we need to try to shed more light on, because obviously he's done a great service to many people over the last 30 to 35 years.
He absolutely has. And it's sort of a crime that no one else is sort of walking in his footsteps, because there's nobody in Scandinavia that has the same kind of expertise that he does when it comes to lymphedema.
I can think of someone. She's wearing a pink scrub top this evening. That's one. And it's time for many, many more. I've often said on this program, of course, my background was cardiac surgery and vascular surgery, and I've been specializing in venous disease for almost 20 years now. But if I were a young surgeon, I think I would be very much interested in lymphedema surgery, and lipedema surgery, and all the facets of it, including liposuction, lymphovenous anastomosis, and lymph node transfer, because I think it's going to be a combination of those things ultimately.
Absolutely.
Balance, because there's a huge need, such a tremendous need, and no one to serve it.
Right. Absolutely.
Very few. That's for sure.
Very, very few.
Dr. Kleppe, beyond the surgical treatment, the other sort of people in healthcare, the therapists, the occupational therapists, and physical therapists who are usually right there on the front lines, doing, the massage and the drainage techniques. Do you find that because there's a lot more attention now being paid, both in our country and in yours, do you find that there are more of those specialists coming about, like because of the need, and is the training there sufficient?
Vein Formula 1000 and Lymphatic Formula 1000 from Vita Support MD are backed by science and sold in doctors' offices. If you're a physician who may be interested in prescribing or selling these excellent nutraceuticals, please call 862-246-7877 to speak to a representative today.
In regards to the physical therapists, occupational therapists, they've been treating lipedema for years, way longer than we have. They've had a lot more focus on it, and they're a lot more organized. There's a Norwegian Lipedema and Lymphedema Association, and they have on their website, they have a physical therapy list where you can go in and register where you're at and find a list of physical therapists that have extensive experience with it, so that you find a physical therapist who knows how to treat. And so that system has been going for a long time. When it comes to the surgeons that are learning lipedema surgery, I think that there's definitely a big gap in regards to the training, because almost no liposuction is done in government-run hospitals. And so that you basically are learning it from your colleagues. You don't have fellowship systems like you do in the States. And so it's a learning by seeing and then, doing afterwards, or paying for for courses to go to. So I actually was in Barcelona last year for learning high definition liposuction. And that's really, opened my eyes to, I was hands-on surgery for 2 days, and it was an incredible experience, and really, lifted my depth of knowledge in liposuction. So I think, it's a lot of what you put into it yourself is how good you will get, I think.
And I have a question. I'm so sorry. When you do liposuction, do you go just to the superficial fascia, or do you go below too?
I do. I empty the whole deep fat layer. So I'm going right above the muscle fascia. I'm taking the deep fat mostly, and then just, doing a lighter superficial liposuction.
Interestingly, because I do a lot of ultrasound, especially when I do the diagnostic, and it seems like there is different hyper-ecodensity or hypo-ecodensity when you have the superficial layer and deep layer.
Right. So I think I also do ultrasound, and I see, especially when I'm doing the diagnosis, I can't remember what the test is called, but it's the one that's right above the medial malleolus, where you do you measure the depth of the subcutaneous tissue, and then you, without pressure, and then you push the ultrasound probe as hard as you can to see how much you can compress the deep fat. And I see, the superficial fat is a lot more compressible than the deep fat. The deep fat is, the one that barely moves. When we're doing liposuction, we basically try to empty that area as much as we can. And, their pinch afterwards, you can actually squeeze their skin together rather than, just grab it and not have much hold in it at all. I mean, not be able to pinch it at all. So.
Well, I will, if I may, I'll send you some questionable ultrasound studies, so we can perhaps work together.
That would be very, very interesting. I would love that.
Yeah, I'm now interested in changes in fascia, because
Okay.
it seems like when I do the conservative management, initially you don't see much fascia. There is so much disruption, superficial more than deep. And then after the treatment, I see beautiful and maybe even thinner fascia than before. So, and nobody did any studies on that. And I think we can combine and see how we can come up with the same results.
Absolutely, absolutely. Yeah, when you mention that, sometimes I find it's really hard to find scarpous fascia. It's not homogeneous. It sort of is, it's hard.
Many times I see the fascia bifurcating.
Right, exactly. It's almost 2 layers of fascia.
Right.
Yes.
And when I see patients with a lot of inflammation, the fascia is very thick.
Mm-hmm.
So there is some great correlation. I just became a member of the Fascia Research Society, so I want to go there and learn more about this fascia business.
Absolutely. That's super interesting.
Good.
And actually, the question maybe to both of you, because I think we own this to our listeners. Could you tell us, how do you diagnose lipedema before even you treat them, the patient? How do you have this almost certainty that this is lipedema and nothing else?
Well, I mean, there's unfortunately no blood test that we can take or anything super concrete. So I've tried to make a systematic sort of walkthrough that I do of all the physical problems that they have and the symptom debut and stuff. And I use, there's a German set of clinics in Germany called Lipocura. And they've developed a calculator that is for physicians that you can basically use to then come up with a score to see how high they score on this calculator. And it goes through all the questions, so it becomes a really systematic process, and that sort of helps, set the diagnosis for the patients instead of just feeling like I think you have lipedema. From all of these symptoms. So that makes it a little bit more concrete. And that also includes the ultrasound exam on the leg.
One of the things that I would say is that, considering our conversation this evening, knowing that there's certainly a paucity, if not a complete absence of lipedema in Asian patients, we would have to surmise that there is some genetic component, and perhaps at some point there would be a genetic test to definitively make the diagnosis. But as you can correct me if I'm wrong, but as far as I know right now, there is not one.
That's right. They haven't found the lipedema gene yet, but they do say that it's an autosomal recessive, or is it autosomal dominant? I can't remember. It's definitely, there's an inherited component, but I'm also seeing a lot of patients that have no family history of lipedema. And so that it's just, showing up. And I've had, patients come in with their super skinny parents, and you're wondering how, they don't look anything like their daughter does. And they can't think of any aunts or uncles or grandparents.
I'd bet on autosomal recessive then, if we're not sure which one.
Yeah, it must be recessive. You're right.
No, because Emily was just telling us that one parent can define the presence of the lipedema. If one can define, I would say that it might be dominant, actually.
Unless the other one has a recessive gene as well.
Right.
Well, if they would, no,
I'm outside my comfort zone here, Monica.
If Asians do not have the disease, they cannot have recessive gene, because that would show up.
That makes sense.
Yeah.
That makes sense. And you could also have, I mean, genetics has become obviously very complicated with partial penetrance and all of these kinds of things. So it'll be interesting when we find the gene. You know, one of our colleagues, a very dear friend of Dr. Glavitsky, Joe Raffetto up at Harvard, has recently been working hard in identifying genes in venous-related disease and so forth. And one of the things that I found so fascinating is that he's been able to identify a gene associated with venous stasis ulcer, which is, I think, incredible, because for many, many years, we saw patients with relatively mild-looking venous insufficiency who would have a rip-roaring venous stasis ulcer, and then others with just tremendous obvious venous insufficiency and varicose veins and hemosiderosis and all kinds of changes, and never develop an ulcer. So there are more genetic components to more things than I mean, that would have never even occurred to us 10 years ago. We just thought it was strictly a mechanical venous hypertensive kind of phenomenon, a pressure-related phenomenon. But we're learning more and more every day that genes define everything from lipedema to personality and so on and so forth. It's a fascinating subject.
And I have the question. So once you diagnose the disease, so do you have the indication for the liposuction for all those patients, or are they?
No. So first off, I want all my patients to take a deep dive into their what they're putting in their mouth, and really do check out their dietary patterns and change accordingly. And, you know, there's no one size fits all when it comes to diet and nutrition for lipedema, what works, but we know that low carb diets and Mediterranean diets are definitely, and intermittent fasting are definitely a combination of those that can have an effect on their pain problems. And we also, you know, there's also oftentimes overweight issue, and we try to have them lose as much weight as they can before we consider surgery. Another thing too is that we see when they've used compression garments for at least 3 months, that softens the fat up and makes it much easier to do the liposuction, and it gives a better result. And by that time too, they've gotten used to using compression garments, and we'll be able to plow through the post-operative care where they need to use a minimum of 3 months more before they can start, you know, seeing if they can go without it.
Yeah,
so you consider the compression after surgery?
Absolutely.
Yeah.
Because there's a huge internal wound and a big dead space that needs to grow. And if you don't have compression, there's a lot of wound fluid and seepage and stuff afterwards, and you need to have that compression to get the fluid out, and then to allow the wound ends to heal towards each other, so you don't have a seroma or other complications like that.
You don't routinely leave any drains, I would imagine.
You know what? It's sort of hard to put drains. We've considered it, but I think, you know, we don't close the openings that we've made, so that it's sort of an automatic drain when they're up and moving around. It just sort of shoots out with with the wound fluid. So it's a little gross for the patients, and you know, I try to inform them well enough so that they're prepared for it afterwards. But I don't think there's anything that can prepare you for how it's going to be after surgery. It's a big change.
Yeah.
So yeah.
Well, you talk about diet and weight loss. We had a recent guest talking about ketogenic diet and their great belief in that. And we know that there's some controversy. It's, you know, there are pros and cons and believers and non-believers and so forth. I guess the jury's still not in on that particular subject. But we were also at a recent meeting. I was at a meeting speaking in Orlando, And one of the surgeons there was talking about his experience with GLP-1 agonists in the lymphedema subset, which I think is a new thing that people are looking at. In his experience and his knowledge base, they were not seeing, and you can comment if you would, they were not seeing the same kind of results in lipedema patients as non-lipedema slash run-of-the-mill overweight and obese patients.
Right. So I would sort of have to agree. I think that, losing weight and having lipedema is a huge challenge. And like I was mentioning, the ketogenic diet, it works great for some people. Other people have no changes at all. And that's why, trying different diets like intermittent fasting with an anti-inflammatory or Mediterranean diet that has, low fat and is more, doesn't cause as much as an inflammatory response in the body, works better for them. But, with the injections for weight loss, I think that some people also respond pretty well, but they get to a point where if they haven't changed their lifestyle, they're not going to see more results because it helps you a certain amount, but it's not going to take you all the way necessarily.
Yeah, the other thing that I would say is I always wonder about this. I mean, it's kind of a radical idea, and I don't know that will ever be done, but I suppose a study could be done on a purely voluntary basis. When I was in medical school here in New Jersey, one of my professors, who was a very elderly man at that time, many years ago, had done some of the seminal research on, believe it or not, the relationship of calories to weight and obesity and so on and so forth. That had to be proven that there was a link. And in fact, there are still, you hear some of these people trying to dismiss the relationship between calories and body mass index and weight and adipose tissue and so on and so forth. But his work with some others was essential and seminal in proving that there is a relationship to caloric intake and obesity. And the way that he did that, quite simply, was in an inpatient program. People had to sign a waiver and basically commit themselves to a period of time, which could be 3 to 6 months inpatient, and you had to agree to eat only what was provided to you. And some of these studies that they did were extreme. I mean, extreme to the point where the diet consisted of dietary supplementation, black coffee, and water.
Wow.
I mean, this was back in the 1940s and 1950s, I'm talking about.
Right.
And everyone lost weight. It comes as no surprise, right?
Not at all.
everyone achieved a normal body weight. I don't know if they were doing body mass index in those days, but today we would call that starvation.
Right.
But who can live that way and who can starve themselves? But it would be interesting to see how, with real calorie restriction, not starvation in that regard, but whatever the calculated parameter was, if it was 800, 1200. We've had a medical weight loss program in our practice in years past. We no longer run it, but there were people who, through the program, which was under medical guidance, were only receiving 800 to 900 calories a day, which is very, very, mostly with meal replacement.
Right.
Really, really a difficult way to live, but it was effective. The question would be, if you had a non-lipedema group versus a lipedema group, how you would see those results in comparison. And the other thing, of course, is the phenotypical aspect. I think what we have found, those of us with experience here, and I'd like you to comment, of course, doctor, is that even when there is significant weight loss, the body habitus is still generally the same, with the weight being distributed in the lower part of the body and so forth, and patients can still be unhappy or have a level of embarrassment, shame, etc., social stigma, that they would still benefit, I think, from liposuction surgery.
Absolutely. I think that they will, they absolutely do, benefit from liposuction surgery. But I think there was one study published, I think a couple of years ago, with weight loss in lipedema patients, and it showed that the actual, I mean, even though it wasn't very significant, they showed that the volume of the legs with lipedema did get reduced with weight reduction. And when you're in there doing, large volume liposuction, you really want to decrease your risks for the patient as much as possible, so that, if they have lost as much weight as they can, and they're not overweight, and that you really see, because their upper body is usually much smaller than their lower body. And you see when they're getting thin that, okay, you need to stop now, because you start seeing their ribs and their collarbones, and know that, we're getting to a place where we don't need to go any farther. We don't want them to get into an anorexic situation. But then you have a lower volume to remove, which makes it, it will give you safer surgery.
I'm sorry. Yes, I have a couple of other follow-up questions to that, which you've now reminded me of. I've seen a couple of doctors here in the States that we would like to have on the program. We're trying to schedule them. But one of these techniques that I have seen, in addition to liposuction, and you can speak to this because of your physical experience and relationship to these tissues, is that in addition to liposuction, they talk about the fatty tissue being significantly different than fatty tissue that a plastic surgeon is typically used to dealing with, in terms of a more fibrous kind of a situation, and also this business of, or this phenomenon of much, much larger fatty lobules that sometimes are difficult or impossible to even remove through a liposuction cannula. And then they have this technique whereby they'll make some small incisions and actually physically, manually push those lobules out, and they look like 1,000 grapes popping out. So I wonder if you have any experience with that surgery, that technique, and your thoughts on the quality of the fatty tissue itself.
Right. So I haven't had any patients with that kind of fat. Most of the patients, because there's been so much focus on it, are coming with lower stages of lipedema. So they're more stage 1, stage 2, but very few stage 3. And that's where I think, especially when you're going from stage 2 to 3 and above, that you're getting into those big nodulary fat pieces that and I just haven't seen that much of them. But in regards to the fibrous aspect of the liposuction, it's absolutely a lot more work. And that's why, using Vaser and getting that emulsification of the fat, which sort of loosens it from the fibrous tissue, makes the removal a lot easier. So
for our panel, as none of us are plastic surgeons, and for our listeners,
right,
you could tell us about Vaser and the power assisted, and explain those different technologies for us. Sure.
So Vaser is ultrasound probe that you put in. It looks like a liposuction cannula, but it doesn't have, it's not hollow, and it has different rings on the end which send out ultrasound waves. And depending on how many rings you have is how intense that wave is locally where you're running it. So you basically take this probe and you push it through all the fatty tissue. And in the beginning, it's really fibrous and it's really hard, and you've got a lot of you got to work against it. And then as you're working with it, it starts getting softer. And what it does, the waves sort of—
We're not doing any suction in the initial—
There's no suction. No, it's just the ultrasound waves, and they basically emulsify the fat. So they sort of get the fat out of the fibrous tissues and loosen them up, which makes it a much simpler removal of the fat. And it also is more protective of the vessels, the lymph vessels and the blood vessels, so that it's has a protective aspect to it too. So when you're doing the liposuction, we use power-assisted liposuction. That's basically a liposuction that has that vibrates, so that it does sort of that work that we used to do when we had the tulip system. We had to do everything by hand. It does that for us, which reduces the strain on our shoulders and hands quite a bit. And that basically, and that has a suction on it and pulls out the fat.
Yeah, so much less chance for occupational injury for the surgeons and physicians also, which is terrific. Now, what about laser-assisted liposuction?
At Vitasupport MD, we believe in creating the best bioflavonoid-based supplements to support your vitality. Bioflavonoids are found in abundance in nature and support excellent health and wellness. The demands and stresses being put on our bodies in these challenging times are unlike any we have seen before. Support your body with the flavonoids it needs to fight inflammation and oxidation. Unlike other products in the marketplace, Vitasupport MD dietary supplements use micronized flavonoids for optimal absorption and effectiveness. Micronization is an advanced process which creates an ultra-fine powder easily absorbed by the body. At Vitasupport MD, we are passionate about making your good health our life's work.
I don't have any experience with that. I just
they were doing it here in the States. It was supposed to do some of what you were talking about with the ultrasound in emulsifying, liquefying some of the fat, and also helping to seal or coagulate any small vessels and things. So I don't know whatever happened with it, but it sounds like maybe it's gone by the guy if you're not.
I think that there's been a lot of burn injuries with laser liposuction, and that it's not like an ideal form. I mean, we use the most common is water-assisted liposuction and power-assisted liposuction. And now we have new technology like Renuvion or J-plasma, which also helps with skin tightening. And I do that on all my lipedema patients, because when you've emptied a thigh of 5 liters, there's a lot of redundant skin. And even though the Renuvion may not make them super tight, it will tighten them up enough that they don't have to have a thigh-plasty later. And, making those scars, doing that huge surgery is really no fun for either the surgeon or the patient. So being able to make it into a minimal number of surgeries for them is important as well.
Yeah, well, I can tell you I'm old enough to remember it was the very tail end of it when I started training in general surgery, when we used to do the long saphenectomy incisions to take the saphenous vein from the leg to create bypass surgery. And by the time I got to my cardiac surgical residency, that had been replaced with laparoscopic harvesting, thank goodness, because when I was a general surgical resident covering cardiac, the patients had many more problems with those long incisions on the legs than they did with their chest sternotomy and so on and so forth. So I could see why you would be sparing in these thigh-plasties in these patients who already have a number of reasons to have healing problems.
Right.
So it's amazing. There's this new technology that it sounds like from you does actually work in a tightening fashion.
We're seeing great results with it.
It's amazing. That's amazing.
Yeah.
What also is amazing in what you mentioned is years ago, we saw, and I think many people still do, saw ultrasound as completely benign. It's just sound waves, et cetera. But we now know, obviously, based on whether it's the frequency or whatever else, it can be destructive. Sound waves can be strong enough to, as you say, break up tissue, melt fat, et cetera, et cetera. So it has to be also used with great professionalism, training, and caution.
Absolutely.
Amazing.
Kleppe, I'd just like to interject for a minute as a non-medical person. So I'm listening to this conversation and, trying to imagine myself as a listener, right? So perhaps someone's listening now that has lipedema and is really trying to weigh their options and become educated about what to do about their condition. When you talk to your patients about the prospect of surgery, what kind of expectations do you give them regarding, is this the end all be all? Will this sort of cure my condition, or will it only allow me to, live perhaps a smaller size in my limbs? Or what kind of expectations do you give them?
That's a really good question. Because lipedema surgery hasn't been around for a really long time, we don't know the long-term results. There's one study that, isn't on a big number of patients, but it's a 10 years follow-up. And it shows that 84% of the patients operated have a good result after 10 years, but there's 16% that have gotten their lipedema back, or their pain has come back, or the heaviness, so that it's not a be-all cure-all. We don't know, and so that's why we're I guess cautiously optimistic, because we see that after surgery, especially if we have to stage the surgery because the patients have huge volumes that need to be removed, the areas that we've operated, they don't feel that heaviness or pain. And it's almost, once the post-surgical pain is over, they feel a difference between the operated and non-operated areas. So it's almost immediate change that you feel when it comes to the pain picture. And that's really sort of the goal. We also see, especially in young patients that, are coming before they've had children and wanting treatment. I think that's a really a good thing to think about, because we see that pregnancy often triggers the development of lipedema, and that they get, more aggressive progression of the disease. And so, doing a liposuction before that will sort of prevent them from going into a more aggressive stage.
If I can interject, I had that from the clinical point of view, because I see the clinical part a lot. I had a patient who, before her wedding, she wanted to look perfect and she had liposuction. Fast forward 10 years later, she had another liposuction after having 2 or 3 children. And we know that the estrogen influence is tremendous for the lipedema patients. So she had sort of touch-up of lipedema, liposuction, second bout after pregnancies, and 10 years later. So yes, you pointed out it is not a cure. And I think all the patients should know that this is not a cure. And many times patients are asking me, well, with conservative management, can you fix my legs? No, I cannot, and we can improve. And I think we need long-term studies to see where these lipedema patients are. And I think there are many factors. If hormonal influence is great, that's number one. And if they maintain their body BMI in the same frame as they were maybe 10, 20 years ago, they will maintain fairly well. But if someone gains weight, there is no way that liposuction, pre-existing liposuction, would be much helpful.
That's true. Absolutely. And, we can't guarantee that we've taken out all the lipedema fat. I mean, because we're making tiny incisions and doing liposuction, so we can't see the hole that we've left and where the little fat nodules are of the little lipedema nodules that are left. So, we can't give them 100% guarantee, unfortunately.
Well, I have to say,
so you after surgery, you keep the patients on the conservative management with the persistent diet, whatever is adjusted to the patients, as you said, and exercise, or?
Absolutely. A lot of patients have gone from being very physically active to being, incapable of going up 2 flights of steps, just because the pain and the heaviness that comes in that bothers them so much. So that, that also is an aspect. A lot of them are looking forward to being pain-free so they can start working out again. I had a 70-year-old patient who I operated, who was rejected by the government-run hospital because she was too old, but she was completely healthy. So we operated her. And when she came to her 1-year follow-up, she came up in skinny jeans, and she's like, I can go up mountains now. I'm hiking every day. Everything's awesome. I don't have any more pain. And, those are the kind of things that you really live for. And you see that and they've maintained their weight, they've maintained their lifestyle changes, and they really, really get to reap the benefits of the liposuction treatment.
Fantastic.
Well,
So quality of life improves after liposuction.
Absolutely, without a doubt.
yeah, I was just going to add, it's very interesting as we have these conversations, and I think more and more about it and how exciting it is for the future. I think for patients, as more lipedema trained and interested surgeons are going to be popping up, for lack of a better word, around the world, as the knowledge increases, awareness of the problem increases as a real disease, as a fat disorder. It's very exciting. I'm very hopeful for all of those people who are living with a lot of misery, discomfort, and that brings me to the point. It's emotional, it's social, it's psychosocial, it's sexual, it's physical. There are so many aspects to this disease state. And that's why we say again and again here that ideally, I think, centers like yours, Kirsten, are going to hopefully develop in such a way that private centers outside of the state system in countries where that is a major obstacle, and it's certainly becoming a bigger obstacle here in the United States every single day. I mean, really, very quickly, that differentiation between private and quote unquote insured care, rather than calling it public, but insured versus out of pocket, let's say, that rift is becoming more vast every day. But ideally, there would be centers that are really holistic with surgeons, nutritionists, dietitians, psychologists, physical therapists, other therapists like the one that you have in your center, acupuncturists, bringing, again, maybe East and West together, using some elements of so-called, for lack of a better term, Chinese medicine, et cetera. Because it's such a complex problem. It's not just fat, and it's not just, liposuction, that will take care of it. There are so many aspects, and we can go on this subject. And unfortunately, we're coming to the end of our time together. But I have to say, it has been such a pleasure to have you on the show and meet you personally and know you personally. I'm so impressed with everything that you've done in your young career and the trajectory that you're on. And I'm quite sure that this won't be our last visit together. And I hope that we can all meet sometime in person at a conference or something like that. But I thank you for your time, and I congratulate you on this great journey that you're on. And I think it's just the beginning. And I can see already that you have great ability, not only as a doctor and a surgeon, but to communicate. Your empathy comes through, and I think you're going to have a very, very successful career.
Thank you so much. Those are such kind words. It's been really nice being on this podcast too. It's my first podcast, so I was a little bit nervous, and you guys have been amazing.
It won't be your last. Let me ask one more question in case anybody forgets to ask. Kirsten, believe it or not, I have sent several patients here from New Jersey, from the New York metro area, to see Dr. Brorsson in Sweden.
Right.
And I know I have many other patients who are going, I don't know the doctor's name, you may know, some very well-known surgeon in Spain who's quite popular. If a patient here listening to the program wanted to speak with you, consult with you, and maybe even travel to see you for consultation and surgery, how could they do that?
Well, they can find me online, either on my Instagram account and just send me a direct, DM, or they can find me on my website too. If they Google me, they'll come up to clinickleppe.no, and I do video consultations, and I have patients that are coming from all around Norway, so it's not always easy to do the physical consultations. So we do a lot of that.
Wonderful.
And,
Instagram, what is your handle? Kleppe?
Dr. Kirsten Kleppe.
Beautiful.
Straightforward. Yeah.
Wonderful.
Kleppe.
Yes, correct.
Kirsten.
Yes.
Kirsten Kleppe. Dr. Kirsten Kleppe.
Correct.
Perfect.
Wonderful.
Thank you.
And you should come. I will be in touch with you because every other year we have the conferences in Budapest within the Semmelweis University on lipedema and lymphedema. You should be a part of it.
I would love to be a part of it. I didn't know that. That would be amazing.
Yeah. Wonderful.
Yeah, please send me that information.
I'm sure you're going to meet Dr. Eicher sometime very soon at the fat disorders meeting or something like that, for sure.
Because I am still evacuated and I left only in a scrubs. And this is my first month being evacuated, living with my kids in a friend's little house. It's challenging, so I am not able to go to the Fat Disorder Research Society meeting now, but there is going to be big one, the International Congress of Lymphology in Turkey. So I hope that I can meet with you there. I hope that I can move back to my house sooner than later, and then I'll be able to go, I think it's in summer, in Turkey. Last year, the European Group of Lymphology was in Istanbul. Now it's in Turkey.
Well, Emily, you and all of the residents in the Los Angeles area affected by these terrible wildfires are in all of our thoughts and prayers, and we wish everybody the best and safety and good health and to get back to their homes as soon as possible. It's a terrible thing that's been happening.
Thank you, thank you. I was lucky my home survived. 5,000 something homes did not. And it's amazing. I mean, it's unimaginable to drive through the whole town and see only ashes and chimney standing. And it's hard.
Terrible. Sorry to you.
After war, the images terrible. Yeah. And I heard from our friend from Los Angeles that 1/3 of the surgery department physician lost everything.
Yep.
Just everything.
We just left with what we had on.
Yeah.
Yeah. So anyhow, this was fascinating.
Really?
Sorry, I had to run in between to see a patient, but I would love to contact you and maybe I'll send you some interesting ultrasound. And what I showed with conservative management on lipedema, that even after one session, there is an improvement. And I measured that with ultrasound. So maybe we can work. And
I would love that. I would love to have more information. Send it to me.
Yes, it's fascinating to see that. And the Italian doctor, forgot her name now, she showed with the ultrasound 70 megahertz that there is a fluid on the top of the fascia, a superficial fascia indeed, a small amount, but there is a fluid component. So before it was considered, no, there is just a fat, and so now there is a fluid as well.
Okay.
It's fascinating. So we'll communicate.
Fantastic. I look forward to that.
My email so we can keep in touch.
Fantastic.
I'm fascinated that you have fixed scrubs. I have to.
You know what? I love fig scrubs. I can't work without them.
That's all I had when I ran away from the house, which was neighbor's house burned totally. So anyhow, embrace every moment in a life, and you are absolutely brilliant. So continue fantastic work. And I am sure that a lot of my patients would love to get in touch with you.
Thank you so much.
Okay. I have to run to my patient. So this was fascinating. Thank you, Dr. Chubak and team. And I have to contact a few other surgeons who are in our community to join us for the podcast.
Very good. Okay. Ciao, Emily. Ciao.
Thank you.
All right.
Bye.
Bye. Thank you.
Thank you, everybody, for tuning in to LymphCast, episode 64. And by the way, if you enjoyed it, you got a lot of information out of tonight's show, you can support us by going to buymeacoffee.com/LymphCast Network. We'd appreciate that very much. Keeps us going on this end. And again, that's buymeacoffee.com/LymphCast Network. Tonight's show has been brought to you by LymphCast. On the LymphCast, the show has been brought to you by Vita Support MD. You can find them at vitasupportmd.com. They make Vein Formula 1000, Lymphatic Formula 1000. And by the way, Dr. Chubak, my eyes are still good enough to see, I think, over your shoulder. I see some samples of those medicines. Am I correct on that?
Well, it's true. And in front of me, Paul, I do have our latest formulation, the Tri-Power circulation formula. Right? And Dr. Glavitsky is a great fan of this also because she knows very well there's tremendous research and science behind the three ingredients, active ingredients here, which are butcher's broom and hesperidin methylchalcone, which is a form of hesperidin which is easily absorbable, and vitamin C. So anybody can check that out at the vitasupportmd.com website, the brand new Tri-Power circulation formula, and they may find that helpful to support their venous circulation, lymphatic circulation, and their circulation overall. So thanks for mentioning it.
Okay, you better. Just happen to see those over your shoulder at the beginning of the show, and I almost mentioned it then. At least we got it in now. How about that? We also want you to visit our website, lymphcastnetwork.com. If you have a question for anybody on the panel, send us an email, hello@lymphcastnetwork.com. Let's quickly go around the room and thank everybody. The producer of the show, usually she's working really hard behind the scenes, still is, but now she's working hard in front of the camera as well. Dr. Diane Chubak. Thank you, Diane, for everything.
Thank you so much, Paul. This was a great show. I learned a lot.
Yeah, absolutely. Dr. Monica Glavitsky out in Arizona. Thank you, ma'am, for everything tonight.
Thank you for having me.
You bet. We thank Dr. Eicher as well. She had to run to see a patient, the gentleman who had the whole idea behind this show. And now it's already 64 episodes in. Physician, surgeon from New Jersey, Dr. John A. Chubak. Thank you, Dr. Chubak, for everything.
Thanks, Paul. Great show. Really enjoyed meeting Dr. Kleppe. Really.
Yeah, very much so. Again, it's been LymphCast episode 64. Have a great night. We'll see you next time for LymphCast episode 65. Have a great evening.